I'm Spencer King for CardioTube, visiting today with Michael Haude, who is, as everybody knows, past president of the European Society of Cardiology and an expert in the field of stenting, and in particular our interest in bioresorbable scaffolds and this sort of thing. We've all been hoping for years, Michael, that we would have a stent that would go away and we'd have the benefit of the stenting, yet in the long run we'd have nothing. We became depressed about this with this observations on the absorbed stent, and I'm wondering if it's going to come back. What's your take on where we're going with bioresorbables?
Well, Spencer, we historically have to separate between those scaffolds who do have a PLLA-based backbone and the one that do have a metallic backbone, either a magnesium alloy or also iron. Now, if we look back in history, the PLLA versions, the results we gathered clinically were to some extent disappointing. One of the reasons why they were disappointing was that the implantation mode was not as easy, as practical as we do have with our standard modern cobalt chromium devices, the drug-eluting stents. The second thing is that the PLLA absorption time was potentially by far too long, several years.
And we had very, very big struts, right?
Yes, that's on top, because you need to have thicker struts in order to provide adequate radial strength and force to keep the vessel open. With the magnesium alloy, the major difference is that the absorption time is significantly shorter, just 1 year.
So we're jumping already from the polymer-based ones to the metal platforms, the magnesium. One of the problems I remember from the Absorb was that said, well, we just haven't prepared the artery well enough. We haven't we didn't beat it up enough. We didn't create a compliant enough situation so we could totally implant it, because it didn't have the same radial strength. What about these metal ones? What about the magnesium stents? Is their radial strength pretty good?
The radial strength, if you go to the benchmark measurement models, they are better than in comparison to PLLA versions, but nevertheless, they never reach the level of modern cobalt chromium devices. So we have to appreciate that these absorbable devices are to some extent weaker. So lesion preparation to change the compliance of the underlying lesion is extremely important to do upfront before you implant the resorbable device.
So those same kind of same advice for utilizing perhaps atherectomy devices, perhaps fully dilating high pressure, maybe imaging. Which of these things are important?
Currently, the advice for the Biotronic McMorris device made out of the magnesium alloy is to provide a lesion preparation that comes up with a residual diameter stenosis of less than 20%. Less than 20% is by eyeball a stent-like result.
20% based on reference vessel size?
Yes,
by angiography?
Eyeball watching.
By angiography.
Yes,
yeah.
And if you achieve that and then send in the device, you will have a very good result. If that is not achieved, you probably have not changed the underlying compliance of the lesion adequately enough, and that is not good enough to send the device there. So then you have to upgrade your balloon to something like a scoring balloon to better change that compliance of the lesion. But this is something we learned from the PLLA devices, which also holds true currently for the metallic resorbable devices.
So you mentioned the magnesium stent. I think we know something about that, we've been hearing, but you mentioned iron as well, an iron alloy. How does that? What is that?
So the iron devices, they never really reached the clinical setting outside of China. The absorption time of iron with the corrosion you can consider is ultimately long. So what we potentially saw is too long with 3, 4, 5 years for PLLA. Potentially for iron is even longer, and this is potentially the downside. So I don't see the iron version currently getting into the clinical theater of PCI because of that aspect. It's of course a very strong device, no doubt about that. A lot of radial strength, that's on the positive side, but the duration of absorption is excessively low.
So that brings up the question of how long do we need scaffolding? How long do we need a really strong radial strength? What do you think the optimal time for absorption? And there are two things about absorption. I guess one is absorption enough so that you don't have your radial strength anymore, and the other is the material goes away completely. How long should the device be in there before it goes away?
So this is the holy grail question. So if I would sum up all the knowledge that we do have, we should have at least 3 months of scaffolding properties, full scaffolding properties, and an ideal absorption in a time frame of about 1 year. So if you can manage that in that time frame, I think you are close to creating an ideal absorbable device.
And what about drugs on these stents? What's the situation right now in terms of the ability to have drugs delivered?
So it moves in the same direction as with the drug-eluting stent. Usually the polymers, the drug-elution kinetics, and the antiproliferative drugs are absolutely the same than on a permanent drug-eluting stent. So limus derivatives are the one that are going to be used, usually bioresorbable polymers that elute that limus derivative. So that is very similar. The big difference is the absorbable backbone of the device rather than having a permanent implant that stays in lifelong in the patient.
So the ability to have the limus type drugs that affect cellular proliferation and scarring, I'll call it scarring, must be critical for this kind of idea, because we know that the more you injure the artery, the more reaction you get from a smooth muscle cell and fibroblast, and you begin to get contraction of that scar. If you think about scars, they always contract, and maybe even beyond 3 months, but perhaps the drugs block that well enough so that we get to a more compliant, a more benign, if you call it benign structure. The artery becomes more benign over time. Do you think we're solving a problem that's a big problem in cardiology, or are we just inventing a technology and now looking for a solution?
No, I think what we have shown is that we are going to uncage the artery. So whatever's going to happen once the device is absorbed, the artery is capable to either dilate or constrict again in the segment where formerly the scaffold was implanted. This is not possible when you have a permanent implant there. We know vasomotion is of excessive importance for the anti-atherosclerotic process of the arterial wall. So in overall, we still believe this is a very benign aspect of that technology. So the resorption process at all, independent whether it is PLLA or whether it is the magnesium absorption, it's not creating something in the vessel wall which is over excessively exposing scar tissue, because that would mean you will not potentially be able to see this amount of vasoconstriction or vasodilatation, which is exceeding the one of a permanent implant.
Now we use vasoconstriction and vasodilatation as a measure of endothelial function, but do we know, for instance, that endothelial function actually is better with with something that absorbs versus a permanent implant? Is a metallic stent, a regular stent, that prevents any movement of the artery, is that atherogenic in itself? Do you believe that's atherogenic as compared to a bioabsorbable device?
As of today, we cannot give a firm answer to that.
It's one of our
because
theories
it has
that we
never
think,
been tested head-to-head, PLLA versus metallic resorbable devices, for example. The major point that we can say is that if something is going to disappear, if you uncage the artery, if you don't leave a firm, solid thing in the arterial wall, this is better, because otherwise nature would have forecasted it in the evolution in our arteries to have a skeleton there, and we don't have.
And we know that the current stents that we have almost reached the plateau. It seems to be, I don't see any new stents coming so fast now. Everybody's satisfied that the metal stent. So I'm very excited that there's still research and development in the bioabsorbable field, because that would be probably the only step forward that we have in terms of making progress with PCI.
There are some homeworks to do. They are going to be done, at least, which is true for the magnesium resorbable scaffold. Next generation is going to show up soon this year. We're going to see a first in man and then a randomized trial against the desk later on. So I think the story behind is still a very valid one and attractive one. But it's more complex by biology really to come out with a device that is all fulfilling these requirements.
We'll all stay tuned. Thanks for visiting with us.
Thank you very much.